Hi, I'm Barb Green. I know many of you, if not all of you, welcome to our educational programs, which we like to believe are a cut above. What I want to do is talk about polypharmacy, which is taking medicines, sometimes too many, and how that impacts on MS. And the best way to tell the story is through these cases, because these are not real people. If any one of them looks extremely familiar, like it's you, it's not you. They came out of my head, but they're a conglomerate of what I see every day in the office, okay? And MS itself is a disease that causes fatigue. 95% of people with MS at some point will complain of fatigue. For some people, as Dr. Rauschway said, it is the complaint. It is their most disabling component of the disease. But for a lot of patients, it's just a low-level theme all the time. The problem is that MS also causes lots of other symptoms that warrant other symptom treatments, and those treatments and interventions themselves can have an impact on fatigue, right? And the world is not fair, and just because you have MS doesn't mean you can't have high blood pressure, diabetes, or even cancer, and you may be on medications to treat those disorders as well. And the big challenge in our day and age, really, is that care is fragmented, right? You have a primary care provider who my sister called me from Portland, Oregon yesterday to say her primary care told her to do something for the pain in her arms, and when I really drilled down to it, she hadn't seen the doctor. She hadn't even talked to the doctor. This was a phone call with a physician assistant diagnosing her over the phone, okay? So we have fragmentation of care even within offices. We often see multiple specialists for different aspects of care. And although everybody would love to believe there's one big computer system in the sky that has all your medical information, so that if you go to St. Anthony's to your primary care, and you come to Mercy to your neurologist, and you go somewhere else for your gynecology, we all know what the other's thinking, it isn't true. And we don't have one common system yet that allows us to have access to all your medical records at one time. And that leads to problems, which we will sort of see as we work our way through these cases. All right, so case number one, because stories are always better to sort of show how real the real world is. Joan is a 50-year-old woman with relapsing remitting MS who comes to the office complaining of severe fatigue and thinking difficulty. She has had MS for 10 years and has responded well to Copaxone treatment. And by the way, of all of our immunomodulatory or disease-modifying drugs, Copaxone is probably the least offender in terms of making fatigue worse. Now, that's not to say it doesn't have its set of side effects, right? So burning, site injections, divots we call lipoatrophy, and so forth. She works full-time but worries that her fatigue is impairing her performance on the job. She finds that by lunchtime, she is overwhelmingly tired and she just wants to put her head down on her desk. I ask her, is there some place to actually go lay down during your lunch hour and take a 10-minute snooze? No, there really isn't. In the afternoons, she can barely focus and is concerned that she's making errors on her work-related reports. She does get about 7 hours of sleep nightly. On the weekends, she takes 2-hour naps to try to catch up because she's so very fatigued. And of course, if you take 2-hour naps on your weekend, that really cuts back on your weekend available time to do a few things for yourself when you are working full-time, right? Okay. Now, that's not the whole story, because of course she has other MS-related symptoms. And those include a bladder disorder, which causes her urinary urgency and frequency. She's got problems with tone in her legs, too much tone in her legs. And she has a history of depression, which has required treatment. Okay, not an abnormal assortment of things that people with MS often deal with. She's got a few medical diagnoses at age 50, who wouldn't, right? So now she has a diagnosis of hypertension. She has obesity problems. She's got, obesity of course is, anywhere from 40 pounds lighter than me on up, okay? So, you know, we're all called obese now. America is obese. It's a big problem. Low back pain. She's got a low back pain syndrome. You know, many of us have it. You pull your back out one year, and then after that, it's always easy to pull it out again. And she has hypothyroidism, which, by the way, occurs with fair frequency in women with MS. It's thought to be related to autoimmune thyroiditis. That's a second autoimmune disease that a lot of people with MS get, which kind of burns out your thyroid, and then you become hypothyroid. An easy fix, you can fix thyroid, but it is a concomitant disorder. Okay, so she's got her different things that she has to deal with. So look at the medication list. Wow, right? She's got her Copaxone. She's got oxybutynin, which is ditropan, 3 times a day for her urgent leaky bladder. A commonly used drug, particularly now, because it's tier 1 and the cheapest thing they got. So they make everybody get off their milder bladder drugs, the ones that don't cause fatigue, and put you on one like oxybutynin, which has a tendency to cause fatigue, and even in old people can cause cognitive difficulty. Baclofen, she's on that for her hypertonicity, for spasticity in her legs. That's a pretty standard drug in the MS world. Does it cause fatigue? In a minority of patients, but it can. Some overwhelmingly so. I've seen patients who on 5 milligrams twice a day get knocked out. They can't take it. Other patients can tolerate huge doses of baclofen, so there is really a range in tolerance for that drug. She's on citalopram for her depression. That's Celexa, commonly used antidepressant. Most people on SSRIs, that's the kind of like Zoloft, sertraline, like Prozac, fluoxetine, like I'm doing both names in case you don't recognize one. Those are a whole category of antidepressants. By and large, the SSRIs tend to be energizing and make people feel less tired. But about 10% of people will have a paradoxical worsening of fatigue on one of the SSRIs. She's on cyclobenzaprine at bedtime. Does anybody know what cyclobenzaprine is? Flexeril. What's Flexeril? It's a muscle relaxant. In the bad old days when people had bad backs and I didn't have a lot to work with, and I wanted them to stay in bed for a few days to let up on their back, I'd give them 2 things, Flexeril 3 times a day and a little bit of narcotic, and I knew they weren't getting out of bed because it knocked them out. It just knocks your socks off, right? So she's still taking Flexeril on a regular routine basis because of low back problems. I don't know who put her on it. I don't know how long she's been on it, but it's one of her meds. Then, of course, she's taking her levothyroxine. That's her thyroid drug. Okay, she has to take that. She's on 2 things for blood pressure. One of them is propanolol. Propanolol is also known as Inderol. It's a beta blocker. Beta blockers slow the heart rate. What's one of the principal side effects of beta blockers? Feeling fatigued, poor exercise tolerance, because you can't mount enough of a heart rate. She's also on hydrochlorothiazide, another HCTZ. Everybody knows it as HCTZ, a very commonly used blood pressure drug. What's the mechanism of that drug? It's a water pill. It's a diuretic, right? That's great. So she wakes up in the morning, has her first cup of coffee, gets bladder urgency from that, but she wants the caffeine. She pops her hydrochlorothiazide for her blood pressure. That, of course, makes the peeing worse. Then she quickly gets her ditropan on board to control her leaky bladder. Great combo, huh? We're treating a drug with a drug with a drug. All right. Then at night, because she really can't get to sleep easily because she's so worried about everything, her job, her family, God knows what. This is America. We're all worried about something. She takes her Zolpidem. What's that? Ambien. Short acting, but it is a sleeping pill. And then she fails to mention to me until I elicit it on discussion with her that she's buying over-the-counter soy. Who recommended that? Her gynecologist. Why? She's 50 years old. What's she having? Perimenopausal symptoms, hot flashes. What do hot flashes do to your sleep? How many people know about hot flashes. Every woman over 45 knows about hot flashes, and every man who lives with a woman over 45 knows about hot flashes. I mean, I go tearing out of bed, and then you're yanking off the sweaty nightgown, looking for anything else to wear. I had one woman who said, I was sitting at the kitchen table having dinner with my husband. She said, I forgot that the blinds were up behind me. And she just went, oh, I can't stand it. And off she went with her shirt. She's sitting there with her bra, and he's going like that. So hot flashes are a common perimenopausal phenomenon, and they disrupt your sleep in a big way. Okay, soy, cohash, whatever, is a supplement that we often try for that. So what is she asking me for, though? With all of this going on, she says, what I want is a stimulant medication to help me with my terrible fatigue and with my thinking. She wants another drug. She's tried amantadine before, which is an old drug that we use for MS-related fatigue, which has a modest effect. It was originally, it preceded Tamiflu. Amantadine was used for flu prevention in people who had been flu exposed. Doesn't work anymore for that. So she tried that. It seems to up the dopamine in the brain, and therefore it helps sometimes with MS-related fatigue because dopamine is a stimulant in your central nervous system. She wonders if there might be something stronger that she could use now, okay? So what's her exam like? She's 5'4", she's 210 pounds, so she's somewhat overweight. Her mental status is normal. When you test it in the office, it's perfectly normal. Her cranial nerves are intact. That's eye movements, facial movements, speech. On motor examination, her arms are fine. She has a little bit of increased tone in her legs, so that's true. But her strength is okay in all of her extremities. So this lady is not very weak. And her gait is a little bit slow because of the stiffness, and it's antalgic. That's against pain because her back hurts, okay? And it's a little wide-based, which is because her balance is not 100%. So she has MS stuff on her exam. That's mild, okay? But look what she's living with. She's on a laundry list, a plethora of medications, many of which are working against each other, and many of which may be having an impact on either her fatigue or on her thinking. So, you know, the question is it because of the medicines? That's one possibility. Is her thyroid too low and she needs to have her thyroid checked again? Is it because she's menopausal and she's been having irregular periods in which she heavily bleeds? What does bleeding lead to? Anemia and fatigue, okay? So, you know, which of all those factors might it be? So before we're gonna jump to putting this lady on another medicine, a stimulant, that's not gonna allow her to nap on the weekends well, you know, one of the things patients often tell me is, you know, that drug you gave me, Dr. Green, for fatigue, boy, it really wakes my brain up, but the rest of my body is still exhausted and wants to lay down. So the truth of the matter, sometimes with MS fatigue, the best thing for it is rest. You know, you have to figure out how much you can do and how much you need to rest and accommodate that. So if I were to turn the clock back and this lady was on none of these drugs, but was telling me the same story, I would say, you know what? You have MS fatigue, all right? We are gonna have to redesign your work hours so that you don't work as long or that you get a break in the middle where you can go rest. Or maybe you have to come out of the workplace, or maybe you can be a telecommuter and work at home so that you can take an hour nap in the middle of the day. I mean, it is not unheard of that people with MS have such bad fatigue that they really do have to do a lot of other things to accommodate that fatigue, all right? Oftentimes, when I take people out of the workplace, that's when they finally get around to exercising, and the exercise itself, as Alyssa's probably talking about, can modify fatigue and make you feel less tired, actually. It seems contradictory, but it's true. But in this setting where she wants to keep working, where she's cognitively very good, actually, so I could send her for neuropsych testing, I bet you she'd perform normally, but she just can't focus because she has so much drug on board. So what we have to do is chip away, chip away, chip away. And what that requires is communication between the different caregivers. So her internist has to really relook at these blood pressure medicines, because she's got one that makes her tired and one that makes her urinate too much. Isn't there something better for her, right? Her psychiatrist may want to look at the citalopram and say, you know, there's a different SSRI that I bet would be energizing for you. Her gynecologist will want to know, what's her blood count? You know, has she gotten anemic from menopause? I as her neurologist, am going to want to know that. And can I give her a better bladder drug that'll be slow release, long acting, and she won't get this surge of oxybutynin 3 times a day, which might be making her tired. So there are many, many ways to chip at this, okay? And that's what you have to do. And you have to have a coordinator. And frankly, you, the patient, you're the coordinator, because you have to let each doctor know what the other doctor's doing, and then you have to invest the time working with one of those doctors to kind of start modifying everything, okay? So I think I sort of addressed what all those questions are. The stimulant medication may be what's needed down the line, but not until we've siphoned off some of this drug here. I would very much want to get her off cyclobenzaprine. I'd want to get her off the sleeping pill. There are a lot of different ways I'd want to modify this. Okay. Any questions, comments?
I have a comment.
Yeah, sure.
Now, I mean, as you was speaking of the drugs, I know sometimes does the drugs be too strong for the patient? All right, for example, some of the sleeping pills, so they would take the drug, but they don't know what they're doing.
It has a hangover, right?
No, or they can get up and they can fall down a step, but they'll
Ambien is actually a drug that can do that. Can make you goofy, sleepwalk, lose your memory in the night. So some people, that's not a common effect of Ambien, but it can occur. You're right.
So how do you? So if you see that, you gotta
stop that drug.
You gotta stop that drug.
That's right. You don't stick with the drug. I always tell patients, if you weren't having a side effect before this drug and you're having it now, blame the drug first. And if you can't reach us on the phone, just stop it, and we'll talk. Okay?
Gabapentin do the same thing?
Gabapentin, which is Neurontin. And in the end, I'm going to give you all my list of potential offending medications. But I give you that as just a list to kind of look at and know that some people have a bad reaction to some of these meds. Gabapentin for some patients is a lifesaver. It's a drug we use from the seizure medicine family for pain, for tingling, for noxious sensations, but it's a drug that can make you spacey and tired.
Yeah.
And put weight on. For some people. It's not Christmas, it's not New Year's, it wasn't Thanksgiving, it's gabapentin. Yeah.
But like you say, that all these drugs just be reacting different from people, but
different people,
any
right.
drug you see that's doing something.
If you are newly on a drug and you have a new problem that started after you started that drug, blame the drug first. All right. Okay, case 2. Gary is a 40-year-old gentleman with secondary progressive multiple sclerosis. He comes to his neurologist with complaints of right jaw pain. I'm going to read through the whole case, then we're going to go directly to the questions. The pain is stabbing. It's excruciating in intensity. It occurs on and off throughout the day. Pain is sometimes provoked by chewing, and he's already dropped 10 pounds in a few weeks' time due to the pain. Pain has also awakened him frequently in the night. He's been to the dentist. His exam was fine. It was negative for any tooth problem. His primary care physician gave him an antibiotic. Well, it wasn't really his primary care. It was the nurse on call for the primary care over the phone. And since he'd had sinusitis last year, she figured it's sinusitis again, so she gave him an antibiotic. But the pain did not improve, okay? He himself tried over-the-counter ibuprofen and naproxen, no relief. Then he borrowed some of his wife's oxycodone. That's Percocet. She had it left over from her surgery 4 years ago. And he got some temporary relief of pain, but temporary. So Gary calls and is started on a different drug by the neurologist called carbamazepine, 100 milligrams 3 times a day. On a phone call follow-up, he reports that he's a little improved, but he's still having breakthrough pain, so the medication is increased to 200 milligrams 3 times a day. And carbamazepine, which is Tegretol, comes in 100s and 200s. 1 week later, he calls again to say, I'm still having some pain. Baclofen is added at 10 milligrams 3 times a day, which is a starting dose for baclofen. A week later, the neurologist gets a really angry call from the patient's wife. I'm editorializing as I go because this is how it would go down. To say that her husband is lethargic, he's confused, he can barely walk around, he's taking the 2 medicines for the pain, and he's still hurting. And oh, by the way, he's also on a new antibiotic because he did get a really bad bronchitis. So what are you going to do, doc? So he had an appointment for next week, but an urgent appointment was made, and the patient comes in the same day. And he's sitting there in the chair in the exam room, and he's sleepy. Now, you know, we're used to seeing patients who are kind of poorly responsive in the emergency room, but she hauled this guy in, and he's sitting in the chair like this. And you call his name, Gary, and he go back. And so you have to constantly stimulate him to keep him awake. So he's really doped, right? And his speech is slurred when he talks. And his eye movements, when I get him to move his eyes in different directions, they're conjugate, so he's not wall-eyed or cross-eyed. But when he goes to one side, the eyes jiggle. When he goes to the other side, the eyes jiggle. That's called nystagmus, okay? And we'll talk about that. And his pupils are like little pinholes. They're tiny, tiny. He moves his arms and legs okay. I don't think he's having an MS attack. His skin and his mucous membranes are really dry. His mouth is sticking together, and when you pinch the skin, it doesn't bounce back. It just like stays in a fold. That tells you somebody is really dry. He's dropped another 2 pounds since his last visit. Okay, so he's not eating, he's not drinking. Let's start at the beginning. What caused the jaw pain?
What was it?
Trigeminal neuralgia. Very good. Trigeminal neuralgia, also known as tic-douloureux, is a terrible pain syndrome in the distribution of the facial nerve called the trigeminal nerve, not the facial nerve. It's the trigeminal nerve, which is the 5th cranial nerve. So we call it V1, V2, V3, because Roman numeral V is a 5, right? And it's the 5th cranial nerve. And this syndrome occurs either in the 3rd branch, the 2nd branch, or the 1st branch of that nerve. More commonly V2, V3. And he's pointing to his jaw here that's killing him. So he has V3 distribution pain that often feels like it's coming from your teeth. And this is, I want to jump off a bridge pain, okay? It is terrible, terrible pain. The other name for trigeminal neuralgia is tic-douloureux. Tic-douloureux is French for painful spasm. And what happens is people get the pain and they kind of spasm up their face and hold their face because it is so incredibly painful. And then it subsides. And then they get another one. And the pain lasts 10, 15, 20, 30 seconds or more, and then it subsides. But in between these stabbing pains, they'll have this sort of low-level achy pain that never goes away. So it's a terrible syndrome. It occurs in people without MS, and usually it's people in middle age or older. When it occurs in MS, it can occur in younger people. So we'll see it in people in their 20s or 30s as well as people in middle age. It is treated primarily with anti-seizure medicines that inhibit the abnormal discharge of the nerve. It's believed that trigeminal neuralgia may come from rubbing of the nerve inside the skull by adjacent veins or arteries that over time rub the nerve, and eventually the nerve just starts discharging on its own. That's one of the theories, okay? But in MS, another theory is that the problem is in the brainstem where the nerve comes in, and that if you have an MS plaque right at the place where the nerve comes in, you'll get the same syndrome. So it is very difficult to treat sometimes. Sometimes it's resistant to medicines, but in the first few weeks, we don't call that medicine failure. We have to make our way through the medicines, okay? So he started with the Tegretol. We bumped the Tegretol, the carbamazepine, to a reasonable dose. We added on baclofen, which is a second-line agent. Baclofen, even though it's for spasticity, also acts at a central nervous system level to inhibit discharges. So that sometimes is a good add-on for tic-douloureux, but it wasn't working, right? So That's his jaw pain. Now, how many patients with trigeminal neuralgia come into my office almost comatose? 0. So something else is going on. What's causing him to be like this? Well, one thing is he's dehydrated, but he's a 40-year-old guy. Most of the time, 40-year-olds who get dehydrated don't become gorked, okay? 70-year-olds do, 80-year-olds do. You just give an old lady a urinary tract infection real bad and a little bit of dehydration and she's in a coma. Yeah, Shannon? 5 minutes. Oh, that's what 5 was. I thought she was raising her hand. I thought she was going to give me her comments. I'm sorry, what? Oh, yeah. What tells you that? What tells you that on the exam? The pupils are pinpoint. What does that? Morphine. Okay, heroin, morphine, narcotics. He's been snarfing his wife's medicine. I asked her, how much of that Percocet did he take? She says, I don't know, it's all gone. I think I had 40. I said, 40 over what? How many days? Well, maybe 3. I go, oh my God. So this guy, and that was old, but it was still working. All right, so this is a case of acute polypharmacy. Oh, and by the way, what's the antibiotic he's on? Erythromycin, an old tried and true antibiotic, not used very much anymore, but useful for sinusitis. What does that interact with? Tegretol, it drives Tegretol levels up. So although this guy should have tolerated 600 of Tegretol, no problem, he put a drug on board that shot it up. So he had to be shipped by ambulance to the ER. I didn't even trust for him to be walked to the door, okay? He had to be I'm teaching. I'll call you back. Okay, give me 15. Is it on the film? I'm sorry. I have an old debilitated mother. I have to keep it on. So anyway, lost it. So he's toxic from his Tegretol level. He's toxic from narcotic overdose, which needs to be reversed. He's dehydrated, and what you don't know till you get him to the hospital is he's so severely dehydrated, he's bumped his creatinine. His kidneys aren't working well, okay? So he's put himself into sort of an acute renal failure, which also makes people comatose. So this is an exaggerated example, but we see this. This is a terrible pain. I have seen people narcotics themselves overdose. And the truth is, I will sometimes, if he had just called and said, this is intolerable, I got to do something, I would have sent him over to the ER. I would have put him in the hospital and given him IV narcotic for a short time while I get more other agents on board carefully, okay? And then if over time somebody does not get control with medications of their trigeminal neuralgia, then there are procedural things that can be done. Radiofrequency ablation is something neurosurgeons do. They go through the sinus cavities to where the nerve is, and they can zap the nerve and just sort of shut down one branch. You might end up with a little numbness, but then the pain is better. Other things that are being done now, the gamma knife is a form of focused irradiation that they irradiate the branch of the nerve. And then even major surgery is sometimes needed in MS patients, which is called microvascular decompression, where they literally go through the skull and the back and they move the veins and the arteries off the nerve. Okay, they put sponges in between. So those are extreme procedures, but sometimes needed to fix trigeminal neuralgia. And the sad thing about trigeminal neuralgia in MS is that it can get better on one side and then you get it on the other side. And in MS, people are less tolerant. If I have a small woman and I'm trying to give her enough Tegretol to kill the pain, I sometimes can't do it because it makes her so drunk and so toxic. So there are these problems with even a limited polypharmacy for a limited syndrome in MS that can put you over the edge. So you have to be very careful in using medications. You have to be informing of all treaters. Had he informed the internal medicine office that he was on high-dose Tegretol, perhaps they would have looked it up and realized not to give him erythromycin and so forth, okay?
How do you spell that
Trigeminal neuralgia, Trigeminal. And neuralgia is Neuralgia. It's a syndrome which at the beginning most people think they have something wrong with their teeth. Bad dentists agree with them and pull things and fill things and cap things, and then they realize they still have the pain. Good dentists go, oh my God, you've got trigeminal neuralgia. Get to your neurologist. Okay, last case, and we only got 2 minutes, right? 2 and a half? 1.5? 2. Okay. But this is another problem with polypharmacy. So this is a 30-year-old woman with only 2-year history of relapsing remitting MS. She comes to the office and she says, I'm so fatigued. She's concerned that this might be a prelude to an MS attack. And that is a true concern because a lot of people, as they're getting an MS relapse, one of their first symptoms is their fatigue begins to intensify. It seems like when inflammation goes up in the brain, just like Dr. Rauschway was talking about, it induces the fatigue symptoms to be more intense. That's not everybody, but some people. So she's worried that this may be a prelude because she had gradually worsening fatigue in the months before her very first MS attack, which was an episode of ascending numbness at that time. She's not having numbness now. She's not having weakness. No other new complaints neurologically, just the fatigue. Now, she's working part-time. She has 2 children, ages 1 and 4, so she's got little kids that keep her busy. Her husband has a traveling job. He's in sales, and he's gone a lot of the time. She shoulders most of the household tasks and the kids on her own. She does have other disorders that complicate her MS. What are they? She has a history of anxiety attacks. She has anxiety disorder. She has attention deficit disorder, which has been known since she was a kid. And she has restless legs syndrome, which is a familial thing. By the way, restless legs occurs with a much higher prevalence in MS than in the general population. So it is a real thing. But in her case, her mom had restless legs, her grandma had restless legs. She has also chronic daily headaches. Migraine runs in the family, and she used to get headaches, monthly around her periods, but then they morphed into something called chronic daily headache. And we see lots of people with that too, who every day they wake up with a little headache, and as the day progresses, their headache gets worse. So she is a non-smoker. She has a hard time getting to sleep at night, so she medicates herself with 2 glasses of wine just to unwind after the kids are in bed. So here's her medicine list. What is she taking? And so as I go down the list, I'm going to, again, analyze what we're seeing here. She's taking beta-seron. Of all the disease-modifying drugs, it's the biggest offender in causing fatigue and depression. 2 things that this woman is at risk for. She's on ibuprofen, which she takes around the time of her injections. That's reasonable. She's on sertraline. That's an antidepressant that's used for depression, anxiety. She's taking alprazolam. That's Xanax. She takes it twice a day for her anxiety. She takes trazodone at bedtime. That's also for sleep. So she's medicating with the 2 glasses of wine on top of the trazodone to help her sleep soundly. She takes Primopaxol. That's for her restless legs. That's Mirapex. Mirapex has a number of side effects, one of which can be fatigue, okay? She takes vitamin D3, that's good with MS. She takes Adderall in the morning for her attention deficit, and it also has a stimulant effect. She decided that trazodone and the wine weren't enough for her sleep at night, so she's bought herself some melatonin, and she's taking that at bedtime. Because of her terrible headaches, she's taking 100 milligrams twice a day, which is a pretty sizable dose of Topamax, which is topiramate, which is an anti-seizure medicine that's also FDA approved for migraine prevention. Unfortunately, it's not really preventing her headaches, and Topamax has the added bonus of causing cloudiness in your thinking, memory loss, confusion, okay? And then, because she has lots of headaches, on a daily basis, several times a day, she pops a Fiorinol. What's Fiorinol? It's an old, tried and true headache drug. No, it's not a narcotic. It's got caffeine in it, it's got aspirin in it, and it's got butalbital, that's a barbiturate. And that is a sleepy-producing drug. I'll just tell you quickly, when I had very young children, and I have a husband with migraine, I gave him some Fiorinol to use for his migraines judiciously. And one day I came home from my 12-hour day, and 2 kids were playing in this room, and I go, "Where's the baby?" And they go, "We don't know." And I say to my husband, who's laying on the couch with the washcloth on his head, "Where's the baby?" And his speech is slurred, and he doesn't know. And I go, "What did you take?" "Well, I took your Fiorinol." "How many times?" So my husband was drugged. The baby, fortunately, was just crawling in the next room. But he was knocked out. That's a normal, good-sized man without a neurologic disease who'd only taken 3 Fiorinol, but he took them too close together, and he was zoned out. Okay. So you see right away this woman's got a lot of drug on board. She's 30 years old with, 10 drugs? That's a terrible situation. She's got a normal neurologic exam. What's she doing on 10 drugs? That's what's in my head. Do I think she's having an MS attack? No, I think she's having a polypharmacy breakdown here. She's taking drugs every day. She's taking drugs that treat her drugs. She got to take things to sleep, then she has to take things to make her alert and awake. I mean, this doesn't make any good sense, right? And then as we talk, okay, her exam is normal, but she's fidgety. She's shifting in her seat. She's anxious. And finally, she breaks down. She starts to cry. Why? She tells me that her marriage is in trouble. What's going on? Her husband's upset because when he comes home, she doesn't want to go out and do stuff. And the house is a mess. How come she never cleans it? How come she can't keep it straight? I mean, after all, he's on the road all week. He's relying on her, and she only has part-time work. She doesn't work full-time. So how come she can't keep the house neat? And how come she doesn't want to cook? And why is she lying on the couch when he comes in after the kids are in bed, drinking her wine? So she's worried, and she believes her marriage is at a break point. So what you really have here is a spiral, right? She's got a neurologic disease that indeed may give her some fatigue. Layered on top of that is she has more responsibility even than the average person, because in addition to working a part-time job, she's doing the full-time homemaker as a single parent most of the time. Layered on that, she has anxiety problems, right? And she's medicated for them, but on top of that, she's self-medicating with a medication that's not really good, which is alcohol. And I can tell you that 2 glasses of wine in a small woman is a toxic level of drinking for a lot of women. Okay, women do not tolerate alcohol well.
Red or white?
It was red. I don't know. Red or white. You're gonna switch? Is that what you're telling me? So I think, this does not get addressed by giving somebody another medicine. You gotta chip away at the list. You have to figure out what's making her headaches worse. You have to take away addictive doping medicine, which is Fiorinol. You have to take away stupefying medicine like Topamax. You have to take away medicine, period. The neurologist needs to talk to the psychiatrist, and the patient, or if there is no psychiatrist, if the psychiatric medicines are being provided either by the neurologist or the internist, it's time to get somebody's psych on board. This woman may need counseling. She and her husband may need counseling together. There has to be educating of her about the disease and the meds and her behaviors. There has to be educating him about the fact that someone with MS may not be able to handle all that she's handling. Sometimes you get rid of the part-time job and just say, do the homemaking, and you give somebody the counseling, and you get him educated, and there's a life change for everybody. So communication between the partners, communication between the physicians is key to avoiding the negative effects of polypharmacy, okay? And I see too many of my MS patients get caught in this trap, And you can't help but have more than one disease, unfortunately. Lots of people have MS plus, but you still have to be very wise and very informing of your care providers of who's doing what and how it's going. And there isn't also a medication answer to everything, which is why the other 2 sessions today, right? Because there are non-medication remediations that we can look for to many of the problems related to MS fatigue. Okay? That's it, guys. You're welcome.